Absolutely.
Yeah.
Very good evening, sirs. We are live now.
Good evening to all our registered participants and viewers of the Fitness and Rehab India YouTube channel. This is Chandra Mohan, physiotherapist, founder, the Exercise Testing and Prescription Organization. On behalf of EXRX India and physiotherapists from India, we welcome participants from Canada, Philippines, Pakistan, Sri Lanka, Cameroon, Bangladesh, Malaysia, Nigeria, Saudi Arabia, Kuwait, Nepal, Lebanon, Qatar, Trinidad and Tobago, Kenya, UAE, and India. For today's webinar on the topic of importance of training proximal stability before distal mobility for regaining function of a hemiplegic hand, we have Dr. Ravi J. Shah, MPT Neuro, Assistant Professor. He's having 12 years of teaching experience and presently working in this Sarvajanik College of Physiotherapy, Rampura, Surat, Gujarat. We welcome you, sir. And I welcome our associate, Ms. Tuna. And now I request our resource person, Dr. Ravi J. Shah, to commence the session. Please, sir.
Right. Thank you very much, sir. First of all, I'd like to thank all the organizers for giving me a chance to have a talk on the important topic what we're going to discuss today. Now, as the agenda of the present topic states that should we be hasty in seeking distal mobility? Well, usually when it comes to a hemiplegic hand, what we usually are interested in looking forward to is a person getting as mobile as possible and or as functional as possible to the earliest. But in the haste, we usually make a mistake of not taking care of what exactly is the shoulder doing when the hand is going to be functioning on its own. So this particular webinar is directed and focused towards understanding the concept of why exactly is the distal mobility not that important at the stake or at the cost of compromising the proximal stability. Well, usually, as we know of what happens in case of hemiplegia is in the initial state post-stroke, you have got a hand which is totally flaccid and it is totally out of voluntary control because of loss of cortical activation. You can involve corticospinal tract, you can involve the spinal cord control synergies later on, but in the very initial stage post-stroke, what you look upon to is a hand which is totally lying useless. Now, in an attempt to regain the mobility or the functional capability, usually the clients or maybe the patients whom we take care of, along with the therapists who are over enthusiastic in gaining the functional mobility as far as possible to the earliest, we start compromising the proximal stability issues. In an attempt to gain the distal mobility, what we usually look forward to is how fast or how well can the person attempt the closure of the hand. Then, as we are usually guided by the synergy patterns in the upper limb, which usually falls into the category of flexor synergy, we lose the concept of understanding that it is not the closure of the hand what is more affected, but rather the opening of the hand what is supposed to be taken care of. While doing the treatment protocol or while execution of the rehab protocol for the client, we usually look forward to how well the hand as an effector organ can be rehabilitated to the earliest so that the patient can have the earliest concept of regaining the grips or the prehension and the precision concept as far as possible. Well, again, as I've stated before, is it necessary to be in a haste to regain the distal mobility? Well, again, bringing the concept of CPG, what we know of as central pattern generators in the line of control, you need to understand, or rather we need to understand as therapists or specialists in the line of regaining the control of upper limb is that the more compromised use of hand, when I say hand, it is going to be a concept anywhere distal from the wrist, right? In general, as a synonym, the hand is used as an entire upper limb, but that is not what I'm referring to right now. So when we are going to be rehabilitating the hand function as of what we understand anywhere below the wrist, we are talking about rehabilitation or regaining the control of something called as prehension and precision, which are primarily the function of the hand. Now, in an attempt to do so, what happens is that the patient tries to gain the mobility of the entire upper limb at the cost of a very haphazard or irregular recruitment or bombarding the muscle groups improperly, which itself leads to inhibition of the normal regenerating synergy patterns and promotes the abnormal synergy patterns. Now, bringing us back to the hand function, if at all we are supposed to be focusing upon the distal mobility in the very early stage, you need to understand that without the proximal stability at the shoulder joint, which is the primary mediator of approximation or gaining the control of the hand to reach the object of desire, you are going to be missing a very important concept of positioning and alignment of the entire upper limb, which has to be the primary resource of production of any motion coming from the upper limb. So again, should we be in a haste to gain the distal mobility? The question has been set in line of treatment since years now. And we as rehab therapists or rehab specialists have been working over it since a very long era, over decades, to try to understand that is it okay to let go of the proximal stability and start working on the distal mobility? Because the hand as an effector organ, or let me put it as the upper limb as an effector organ, gains the sense only when the hand is brought into control or into use. If your hand cannot function to hold or approximate itself or fixate it around the object which is supposed to be manipulated or used for any functional activity, the upper limb does not bear any meaning otherwise. So if you turn the table around and again start looking backwards, we need to understand that does actually the hand function have any meaning if your proximal stability is compromised? So that brings us to the second agenda, actually, impact of early phase compensation on later aspects of hand function. A lot of literature quotes that the brain start learning patterns. It doesn't learn individual motions as a whole. So when we as therapists start training the hand function, thinking that hand is only pertaining anything distal to the wrist, we have to understand that for the patient to understand how to use the hand for approximating it to an object of desire, to manipulate it, they will be requiring a lot of proximal stability in form of scapular stabilization, a good activation of all the mobilizers around the shoulder joint to ascertain or to maintain a good alignment of the entire upper limb towards initiation, execution, and termination of the entire activity, which is planned or desired. In case if the patient is in a hush or the therapist is in a hush to make sure that the hand is being used to the fullest in the very early stage post stroke, even when the synergies have not started coming yet, there's always going to be a chance for the brain to start executing or the body to start understanding that a particular pattern of interest is promoted as a good pattern. But then, as we know in case of postural, rehabilitation also, that the brain at times starts uh, understanding that a poor posture is a good posture and then starts getting reinforced toward using that posture over and over again, which leads to deformation of the entire status of the action being performed. Well, the same concept is applied even in case of the upper limb rehabilitation. In case if the patient is not made to understand what exactly is the requirement for rehabilitation or the correct use of the proximal stabilizers, you need to understand that if in case the patient is not made to use the proper channel of muscle activation, there's always going to be a chance for the brain to learn the wrong patterns, the faulty patterns, which need to be corrected at a later date and which is very difficult otherwise. So again, bringing the concept of central pattern generators, which are basically a phenomenal concept of the spinal cord, we need to understand a simple phrase that neurons which fire together, they wire together. That means in the very early stage of mobilization or rehabilitation of the upper limb, if the distal mobility is what is being focused upon, and the patient starts executing the distal mobility, but at the cost of a very bad or a disordered use of muscle activation of the proximal section of the upper limb, there's always going to be a faulty wiring. That is a phenomenon I'm talking about. There's nothing physical about it, but the synaptic chain, or otherwise what we understand as the engram, the sensory engram formation, is faulty. And this faulty engram is going to be reinforced every single time the patient is going to use the upper limb for any or all kind of activities. So what is going to be the impact of these kind of training protocols where the distal mobility is given the primary premise rather than focusing upon the proximal stability is there are high number of chances that the patient will start compromising the usage of scapula at the cost of trapezius, or pectoralis major, or excess amount of internal rotation coming at the shoulder joint, which itself is not going to be self-sufficient enough to perform the entire activity. So bringing us back to how initiation, execution, and termination are affected. Well, distal mobility is supposed to be a part and parcel of execution of any task in pertinence to your upper limb. So if you have to generate a good amount of force or a good amount of executionary capability of the upper limb using the hand, there's always going to be a basic premise need of the proximal stability. So whenever we are going to be training an individual for usage of upper limb, there has to be a very secured manner of understanding or translation from the therapist to the patient regarding how exactly is control supposed to be superimposed on uncontrolled mobility. Bringing us back to the concept of activation of muscles. In case if the patient does not have a proper understanding or is not being given a biofeedback, or let us say a cue and clue format of feedback, which brings us to the knowledge of result and knowledge of performance again, there's always going to be forgetfulness because the patterns are so very well organized in the brain that they need to be overwritten by the correct patterns what we as therapists try to rewrite by making the patient do certain activities during the rehab protocol. In case if the patient starts learning the protocol properly in front of you, but then in the unsupervised time duration of the day, they use the same pattern, the same haphazard manner, or the zone of comfort what they have been using out of your supervision area, there's always going to be a drawback of not having sustained the same correct pattern what we have taught them. Hence, again, as a therapist, we are supposed to be stressing upon or be very stringent upon making the patient understand that if we need a good, foresight regarding how the upper limb is going to be functioning the later part of the rehab protocol or the part of recovery, you always need to have a good control or good understanding regarding how I should not let go of the concept of proximal stability. A lot of time research papers have been emphasizing upon how exactly is the distal mobility very well linked with the proximal stability. I'll not be sharing any of the papers right now because I want to talk more rather than displaying things on the board right now. But then let me just quote some of the articles which have told me or which gives us information regarding how exactly do the distal muscle or musculature of the hand as such are very well linked with the proximal stability. Well, if you need to understand the gripping process, you need to understand that all the long flexors of the fingers or which are crossing the wrist on the palmar aspect to make the fist closed are actually arising from the humerus. And that is what makes it very important for the elbow alignment to be brought into conscience and understand that if the elbow is not aligned properly in line of force action of the gripping process, there's always going to be a compromised action of the grip. On the contrary, again, as we know of now, in the subacute phase, or let us talk about the stage of spasticity, the patient already has started developing hyperkinetics of the flexion mechanism of the wrist and the fingers. So any attempt to forget the concept of proper alignment of the elbow, and then again, we have to bring in the shoulder per se, is going to have a profound effect upon how exactly is the gripping process going to behave in the later part of the hand rehab protocol. So if you have to train the hand function, you have to talk about elbow. If you have to talk about elbow, which is an intermediate organ or the joint of the upper limb, you have to definitely bring in shoulder. Now, the second agenda basically is regarding impact of early phase compensation on later aspects of the hand function. So as I told you, most of the patients, they tend to understand the concept of early usage of upper limb. In case if the patient does not start using the proper alignment of the shoulder and elbow in control of production of a gripping process, there's always going to be a compensated synergy. There's always going to be a diversion of the usage of muscles. There's always going to be a compromise in the gripping process. This indirectly affects the entire execution and the terminal stage of the use of the grip. For example, if you are trying to make the patient understand how to pick up a glass of water which is placed in front of him or her on the table and bring it close to the mouth, there's always going to be a concept of how fast can I go and grip the glass and bring it close to the body. But in an attempt to do so, the patients actually start compromising the usage of scapula, by over protracting it, and there's always going to be a chance of over internal rotation of the shoulder, which by itself is a very, very compromised position for the later part of execution and the terminal stage of aligning the glass of water to the mouth, and which again makes it very, very tedious and strenuous for the activity to be completed. So the concept of proximal stability has to be stressed over and over again. So I'll again like to quote one of the articles which states that early promotion of distal mobility has got a profound effect on compromised proximal stability. So it's a reciprocating effect which the distal mobility provocation has on the proximal stability. So if you have a good shoulder joint, or let me use the word good shoulder girdle to work with, you can guarantee a good hand later on. But then the vice versa process is always challengeable and is always compromised as in terms of whatever the research processes are advocating. So if we are supposed to be looking into what exactly is the impact of early training of distal mobility or the proximal stability, it is always going to give us a very, very compromised status where we actually lose the control over promotion of a good proximal stability at a later date. And in an attempt to actually making the patient able enough to use the hand, we are losing the control over all the rest of the activities what the patient is supposed to be executing later on, because we are looking into the concept of functional rehabilitation of the upper limb for the use in ADL activities. And ADL activities, as we all know, are not happening in the same plane of action for all the joints as in pertaining to the upper limb for the entire process. So if you consider the task of buttoning the shirt versus task of lifting up the glass of water and drinking water from it, the range of motion, the angular patterns or the moments which are generated at the different joints are entirely different. Hence, to train the distal mobility or to train the distal control of the hand, we actually need to individually tailor the process of training or retraining the hand function in context with the upper limb or the shoulder positioning. So if there is a concept of early phase promotion of proximal stability, at the cost of which or at with the help of which the distal mobility is basically executed, it's always going to lead to a better outcome in terms of learning as well as execution of the initiation, execution, and the termination component of the activity. Now, the third agenda for today is role of proximal stabilizers, basically. Now, if you are supposed to be understanding the role of proximal stabilizers, you always need to understand that we talk about compound motions. Now, what exactly is the concept of compound motion and how does hand function get related to it? Well, we have all studied the concept of PNF. We have studied the concept of active mobility. We have talked about, we keep talking about guided activation of the upper limb. What are all these concepts basically relating to? They are relating to making the sensory and the motor patterns being fired by the individual while production of emotion being used in a particular manner so that the pattern which is being relearned or reorganized is happening in the correct manner. Now, if we are talking about the correct manner so strongly, well, what exactly is the correct manner? That again brings us to the concept of uses of PNF. Well, PNF, as we know of, is basically proprioceptive neuromuscular facilitation, where we try to initiate or reinforce the movement pattern what the patient is able to execute as far as possible in the correct direction, so that the dimensions which are required for production of the motion in terms of usage of the muscles are correctly calibrated. There is always going to be an underfiring or overfiring of the muscles, because as I've told you before, there's going to be a faulty synergy pattern being used by the patient to execute the task. In case if the patient starts executing the pattern correctly in the initial stage, but then later on as the spasticity is going to get dominant, and when the rehabilitation protocol is on its peak, what is going to happen is the synergy pattern is going to draw the hand away from the normality what we have been training so far. So again, if we were supposed to be talking about compound motion, we have to talk about the activation of the entire synergy pattern, what is required to be activated in the correct pattern. Now, going back to the distal mobility again, for example, if we are supposed to be training an individual for fine motor grips, and using that fine motor grip for activation of a task which is supposed to be an aerial activity. Let us, for example, brushing the teeth, or let us say, for example, sewing, or let us say, for example, buttoning the shirt. In either of these scenarios, what is going to be happening is at times the shoulder is a fixator, at times the shoulder is a mobilizer, at times the shoulder is going to be an adjunct towards production of an activity at different angles. In all these scenarios, what we need to be focusing upon is there has to be a constant synchrony of usage of the components of the proximal stability to aid, adjunct, and support the distal mobility issues. In case if the patient has started using the distal mobility to their advantage at the earliest possible with a compromised proximal state, what is going to be happening is there's always going to be a very strong adherence of firing of the proximal musculature in an improper manner first, which actually does not allow the distal mobility to come in at the later stage. So again, at the treatment aspect, as when we move on, we usually see that the patient does not execute the task on the entirety with full control. Well, again, the concept remains the same. If you are supposed to be using the distal mobility in full control, we have to guarantee that we have to look into it that the patient has learned the proximal component stabilization properly. Well, to peek into a bit of exercise session or the treatment protocol for the same, usually when we start exercising the patient's hand, we have to have the upper limb supported. Now, what is the concept of having the upper limb supported and then start doing the exercise protocol is, if we know that the patient's distal mobility has started gaining a promotional usage, the patient has started using the hand in certain manners, which should not be stopped because there is no consensus regarding why exactly is distal mobility always supposed to be trained post proximal stability. No, there is no direct linkage. But then again, as the research papers usually quote, that you have to have a well synchronized activation of both the areas because the elbow basically is totally under the control of the shoulder. So if in case the upper limb mobility issues are supposed to be targeted, you have to understand that if the proximal stability is taking time and the distal mobility has started showing some signs of improvement or recovery, you can always have the elbow stabilized or fixated or at least supported on a platform and then start practicing the upper limb or the let me use precisely as the hand functions so that we need not involve any of the proximal firing at all. By doing so, what we are doing is we are isolating the function of the distal mobility or the precision or the prehension activities, which actually allows the brain to understand that we are not firing abnormal synergistic pattern of the proximal stabilizers, and that is why there is no direct linkage happening. Of course, yes, there's always a debate on this particular topic regarding that, sir. Is it okay if we are training the distal mobility without the proximal stability or the proximal areas being involved? Well, it is better not to involve a faulty pattern of the proximal stabilizers rather than, to promote the mobility and then later on work on it on a stressful, in a stressful manner. So it is always okay to start with the distal mobility with the supported elbow or the upper limb section, not to involve the proximal areas unless and until they are stabilized or they are ready to act in the right manner. So one of the treatment options, what we usually look upon to is we have got stations or workstations or hand rehab stations in which there are different activity planned for different kind of mobility issues of the wrist, finger, and the entire palm. Well, in all these workstations, there's always a provision of not allowing the shoulders to move. That is at the sole cost of understanding that we are not trying to promote any abnormal synergistic pattern of the upper section of the shoulder. Now, if in case the question arises, sir, if we are so stringent about not activating the distal mobility at the cost of proximal stability compromise, what exactly are we supposed to be starting with? Well, as the recovery process has been stated in our literatures from decades long, that the recovery always takes place from proximal to distal. Well, the line of control or line of treatment also should usually progress from proximal to distal, because the stability issues are primarily supposed to be addressed compared to the mobility issues. If you don't have the proximal stability, in state, there's always going to be a compromised distal mobility again. So looking a bit into what exactly can be done for the distal mobility issues as compared to the proximal stability issues, we usually go for an understanding of activation of the stabilizers by making the upper limb bear weight of the entire HAT, that is head, arm, and torso, by making the patient use the upper limb for stabilizing the entire upper limb. This is a very good practice because stimulation of the proprioceptors in a loaded manner and an unloaded manner, which we call as a closed kinetic activation and an open kinetic activation, always guarantees the fact that the shoulder is always going to have a control over different areas or different motion planes or angles at which they are supposed to be used. It is supposed to be used so that at a later date, when the intermediate joint, that is elbow, and later on the distal component is supposed to be used, at least we have a well-organized proximal stability component. So looking into the entire session today, again, I would like to move on to the entire part on the entirety that should we actually be focusing upon the distal mobility first? Well, there is always going to be an if and but kind of scenario in this again. To have a broad outline or outlook into this area, what we usually look into is, do we need to promote early mobility? Is there a need to be on a rush to understand that the distal mobility has to be promoted first? Is that so that we can let go of the proximal stability component and look into the distal mobility because that is the effector organ by itself? Again, you have to have a customized approach towards patient. As I told you before, you have to understand that in case if the patient has started showing good signs of recovery of the distal component without the proximal component being affected, yes, definitely we have to start mobilizing or we have to start rehabilitating the hand function, because it is not advocated to have a compromised use of the upper limb when it is into use, when it is usable. So rounding up the first, second, and third agenda, you have to make sure that the entire upper limb is used in a very synchronized manner to use the hand as a whole. In case if there is no dissociation possible, for example, in case of the upper limb flexor synergy, we usually see that the patient is not having the ability to dissociate the shoulder girdle from the shoulder joint from the elbow from the forearm from the wrist from the hand from the fingers. There's always going to be a requisite or a requirement to make sure that all these components are actually dissociated. That brings us again to production of a mass compound motion. And that again brings us to gaining the first control of the proximal stabilizers. Now, again, the usual question arises, sir, which pattern or which muscle group exactly are we talking about when we're talking about proximal stability? We have to talk about scapular stabilization, because it is the scapula, which is a free organ, a floating organ, which advocates the proper positioning of the humeral component, which locates itself very proximally in conjunction with the glenoid cavity. So the glenohumeral component, as of what we usually learn in case of biomechanics of shoulder, is supposed to be looked forward to for a better usage or a proper usage on the entirety of production of the motion. In case if the patient does not have a good stability of the shoulder joint, which is at the cost of scapula, it is not advocated, it is not advisable to start following the distal mobility component activation, because again, if we go back to the old discussion as of what we've been going through for the last 20 minutes, you are going to have a very bad or a compromised status of the upper limb, because the entire push and pull mechanism of the leverage of the finger and thumb or the flexors and the extensor component of the hand is dependent upon how exactly is the humeral and the forearm component being located. Compound motion production always advocates that the motion is going to be linked from the proximal till the distal most component. In case if the patient is having difficulty in understanding the activation or the firing pattern, it is always better to break the entire motion into components or subparts of the motion and then start practicing on the whole. So we have a lot of protocols like proprioceptive neuromuscular facilitation, where you have got rhythmic initiation, rhythmic stabilization. We have got certain components or approaches like motor relearning program or Brunstrom approach, etc., which advocate the fact and stress upon it that you have to first analyze the motion which the patient has learned on his or her own, or maybe with our control teaching, based upon which you have to start isolating the components of the motion. As I've told you before, there's going to be three areas of interest, that is initiation, execution, and termination. So based upon these three areas, you are going to be targeting whichever area seems to be the weakest. So again, recalling the rhythmic stabilization and rhythmic initiation, or maybe hold, relax, and contract, relax patterns to maybe, activate or inhibit the wanted and unwanted pattern of motions. We can always guarantee that we have taken care of and we are in full control of the areas of weakness of the entire motion, and which indirectly links itself to production of a good motion in good control. The hand function, as in what we talk about as of an effector organ being used to produce a meaningful activity, always depends upon what is the desired termination point. The termination point always depends upon how well the initiation and execution have been taken care of. And that again brings us to the same fact that if we want to use the upper limb to have a good termination as desired in the initial stage of the movement production or planning, you always need to have a good, control of the scapula. Now, if we are supposed to be talking further in detail about how exactly the scapula have an impact upon the distal mobility, we always have learned that a hemiplegic hand or a hemiplegic shoulder is under a profound effect of enhanced engram-based synergy post-stroke, which is dominating the counter side. So, for example, for the upper limb, we have got a flexor synergy dominant. We have to understand how exactly are we supposed to learn or make the patient learn how to inhibit the synergy pattern. In the process of doing so, we usually think of how well can we pull the entire upper limb out of this synergy pattern. But then the concept of pull does not guarantee voluntary activation. Please try to grab this point well in the mind. Voluntary activation cannot be infused by dissociating patterns passively. We have to make the patient's body and brain learn how to activate the counterside musculature opposite to the direction of pull of the dominant muscles post spasticity or in a synergy pattern, to make the entire motion happen on voluntary basis. So if we move on to the brainstorm staging or categorizing the tone based upon the synergy, we all know that stage 3 is basically the high stage of spasticity, post which the spasticity starts declining in stage 4 and stage 5, and stage 6 usually, which is said of as not all patients have the luck of getting that stage 6 of full voluntary control. Well, in stage 4 and stage 5, we usually have to start focusing upon the primary issues of compensated movement patterns at the cost of uncontrolled synergistic motions. And that is exactly where, again, the question of distal mobility and proximal stability stands still. In this particular stage, or in these two stages, in case if proper care is not taken regarding the activation, it is always going to lead to a compromised use. I've seen a lot of patients, it's a testimony, of course, I don't have any proof regarding this right now. I've seen a lot of patients who have been rehabilitated to use the full upper limb synergy in normal manner. That means they can use the distal most extremity points in the full usage, but still they are not using the upper limb. They have the same attitude of keeping the limb like this. Now, why exactly do we have this, even if the rehab protocol has been able to mobilize the entire upper limb with full voluntary control to use the entire upper limb to the desired motion? Well, again, going back to the initial part of the talks, you have something called a CPG. So like in the previous lecture, I've been mentioning in the hemiplegic gait area, if the patient has been brought to you in the very early stage of rehabilitation post-stroke, there are always chances to have a supervised 100% control in case of inpatient facility over any and all kind of motions the patient is going to perform with the upper limb and the positioning issues. But in case if the patient has been brought to you in the subacute stage or at the stage at which the patient has already started learning use of the distal component of the upper limb and the proximal stability being compromised, there's a big question mark towards whether or not the patient will be able to reorganize the patterns in the correct manner, because CPG, central pattern generation, has already taken place. Now, central pattern generation basically is a phenomena which is taking place at the spinal cord level, which has to be inhibited, or let me use the word controlled and regulated by the upper motor or upper neurons, central cortical region, so that they can be diverted in the correct direction. That is exactly what I've been telling initially, that if the patient is allowed to use the distal mobility without proper consent of what is happening with the proximal stability, this so-called faulty synergy pattern, rather than getting corrected or dissociated enough to use the entire upper limb as you wish and will to produce a desired motion, instead of it, there is always going to be a very strong linkage of the reinforced pattern of synergy, because there was no inhibitory control from the upper section of the cortex. So again, bringing us back to the central area, it is not at all advocated to be in a haste, basically, to use the distal mobility section at the cost of the upper or the proximal stability. If in case the patient stresses upon the point that, sir, I have now started using my hand for gripping, should I not use it for my daily routine procedures? Well, the question always has to be answered in a manner so that they understand that the entirety of the movement pattern is not being controlled right now. So you have to be patient enough to understand that if you want the use of the hand to be happening in the correct direction, you always have to bear patience enough to understand how exactly is your proximal component acting. A compromised upper limb post-stroke in subacute and chronic stages usually is a result of a bad or an improperly guided hand function post-stroke. That usually is because of a haste both from the patient side and the therapist side in understanding that you should not be promoting faulty patterns. You should be looking forwards, understanding and activating the right pattern, so that the later part of the rehabilitation process can be taken care of in the proper direction. Again, concluding my session right now, because I think I've spoken enough on this. We as therapists or as rehabilitation specialists need to understand that unless the synergy pattern is taken care of, unless the patient has got voluntary control over the entire movement pattern, unless the patient has started learning the initiation of an activity, the executional control and the termination control, there is no meaning in advocating hasty or early use of the upper limb, because that entirely is going to distort the entire learned pattern and move or push the patient again and over again back to the prehistoric stage of using the synergistic activation over and over again. So with that, I'll be concluding my topic right now. If there are any questions, I'll be happy to answer them.
Dear participants, we will be posting a Zoom link now. We request you to join the Zoom and you can raise your questions. Those who are able to write in the live chat box, you can write there so that we can read it out here. And those who want to directly talk can join our Zoom meet. Also, I am posting Zoom meeting link in our WhatsApp groups. So kindly you can directly join our meeting. And subscribers only can write. At least you should be subscribed to our YouTube channel 60 minutes before you like to comment. So if you have subscribed recently, I request you to join our Zoom meeting. Any questions? You can write in YouTube live chat. I request Duna madam, you can post the YouTube Zoom link in groups.
All right, sir, I'm posting. No questions have come yet in YouTube.
Yes, madam. So there is a question from
Yes.
Ravi Sharan.
Yes.
Which muscle group will be focused fast after post-stroke?
Well, as I've been mentioning in my talks earlier on, ideally, the profound impact of the entire upper limb usage rests upon how the scapular stabilization is happening. So in the very early stage post-stroke, as soon as the patient is available and the muscle synergies happen to be firing, see, there is no meaning in activation or talking about activation of the muscles unless the patient starts showing some voluntary control. So usually what we do is we try to take care of the muscle groups in the proximal section of the limb by weight bearing and stabilization or compression of the joints. But as soon as the patient starts showing control of the upper limb, the first line of defense what we are supposed to be preparing with is the use and proper control of the scapular stabilizers, because they are going to be advocating an efficient use of upper limb later on. So to be precise enough, we need to have a good control over the retractors of the scapula and try to inhibit, please mark my point, try to inhibit the use of trapezius and pectoralis major, because these two muscles are known to be not involved in the phase of flaccidity. And that is why the brain starts firing these muscles at the earliest for production of any and all motions at the earliest. So try to inhibit these muscle groups and try to fire the retractors as soon as possible, so that the later stage will have a good stability of the scapula.
Okay, so thank you. The next question is from Shruti Chaudhary. Initially in hemiplegia, there is zero muscle power. What is the time frame to regain tone gradually, and what protocol we can use during a reflexia stage?
Well, Shruti, I need to mention here that we as physical therapists or otherwise therapists from any specialty have to understand one fact, that we do not control activation of spasticity. Although a lot of literature states on the sensory integration component or the occupational therapy journals that you can induce spasticity, as in you can start making the muscle learn or gain spasticity. But then if the question is that, sir, which muscles are we supposed to be, controlling, or when exactly are we supposed to be inducing the movement control, you have to wait for the muscle controls to start show up. That is exactly why in states of flaccidity or no control or no tone, we usually make sure that the muscle integrity is taken care of. And we resort to using our strategies like using of electrical stimulation or splinting or taping, just to make sure that there is enough amount of proprioceptive control or feedback from the sensory aspect of the surrounding area available to the brain. By the time the patient starts learning or the brain starts showing signs of perception of proprioception indirectly, which is going to be shown as firing of the muscle control in a different manner, you have to start learning or you have to start inducing the treatment protocol. Because in neurological sciences, unfortunately, we don't have something like what we have in orthopedic sciences. No offense to the orthopedic science, of course. We don't have time frame like in 2 weeks you'll be having healing, or in 4 weeks you can start mobilization. I'm sorry, we don't have that. So we have something called as a stage or phase-wise correction pattern. We have to have patience and bear patience enough to understand that when exactly is the patient starts, the tone has started flaring up, and this is the right time to start controlling it. I hope I've answered the question.
Yes, any other questions from our Zoom participants? Yes. Hello, who is that?
Good evening, sir.
Yes, Akhil, please carry on.
Sir, how can we prevent the rate of subluxation, sir? Because now I have received a case and it's a subacute stroke, sir. The patient had came to me in the subacute stage, but he is already having for the subluxation, sir. But I was trying my best to recover it from it, but it is now also it is like the same, sir. So how can we manage the subluxation in the hemiplegic cases?
All right. Now, although the question is not a part of the presentation right now, but let me just answer it because I have also been through the same context and situation in my patients. I hope I'm audible, Akhil.
Yes, yes, clearly audible.
Yes, yes. So let
Yes,
me
sir.
just
Audible.
narrate an incident. Yes, yes. So let me just narrate an incident where I was handed over a case of female of 35 years old post-stroke, and she had profound subluxation, and I was required to impart NBT purely to gain control over the upper limb. Well, we need to understand that if the patient does not show a status of voluntary control or active firing of deltoid, which is a primary requisite for prevention of shoulder subluxation, we don't have any option but to recite to purely on the resort of stabilizing agents like taping or bracing or splinting, because unless and until you have got a well-aligned shoulder joint, as we know of in case of hemiplegic shoulder post-stroke, there is a flaccid shoulder and a spastic shoulder. So in case if the shoulder what you have received is a spastic shoulder, you can always resort to inhibiting the spastic muscles, try to correct the alignment, or if the muscle is not giving off, try to inhibit it by using different methods, what we already have in case of physical therapy. Try to stabilize it by splinting or bracing or taping, whatever is available, and then try to make small adjustments in motions towards attaining the entire motion. Because in case if the patient's body is not aligned properly, or let us say the shoulder is not aligned properly, and you try to make the motions happen, there's always going to be a knocking of the humeral head with the acromion or maybe the anterior aspect of the shoulder joint. So it is better not to be in a hurry to promote motions at the shoulder joint. Rather, you need to take care of the deltoid. Now, I have also seen cases where the anterior deltoid, please mark my words, anterior deltoid and triceps are not firing. Now, these two muscles are the primary requisites for reaching an object placed in front of you. So if you have unfortunately received such kind of in case, I'm very sorry, but we don't have any option much to do about it. You'll have to switch over to the second and third line of defense. So in physiotherapy, we usually have a three line of defense. The first is remedial, which makes us understand that, yes, we are in more of understanding that recovery is going to be possible, and let us try to, attain the normality of motion as far as possible. The second line of defense is, I don't think, sir, these muscles are going to fire anymore. I need to go for an alternative motion technique to make the patient gain the motion control. The third line is the patient is not showing any premises of use of the muscle. We'll have to go for compensation. Well, the compensation part is not our line. That is going to go for a more orthopedic science or neurological science area. But in the second part, in the substitution stage, you can always use some external stabilizing agent to see that the movement is happening. At times, rarely, but yes, at times, literature advocates that use of FES helps. Functional electrical stimulation helps. But again, as we all know, FES is not a very cheaply available unit. So if in case you want to know the answer regarding what you can do for this subluxation shoulder, I'm sorry, my friend, but you'll have to resort to the time. We cannot do anything about it right now. I hope I've answered the question.
Okay, thank you,
Yes,
sir.
the next question. The next question is from Dr. Vishnu. Usually in chronic stroke of more than 6 year case, what need to do for hand rehab?
So I think I have clarified the concept of CPG in the very early stage. Now, what usually happens is that in stage of chronicity, again, let me emphasize on the fact, an untreated or an unrehabilitated hand is what we are looking into right now. The patient's body or the patient's brain has already started firing the synergy in the line of comfort or in the zone of comfort. And literature already advocates that a wrongly learned pattern, a single wrongly learned pattern requires a correct pattern to be produced almost 500 times in continuity, which is humanly impossible. So the only premises on which we can rest upon, in case if we are seeing any sign of improvement, even post 6 years, which is usually not seen otherwise, the only leftover chance of activation of muscle is to use some directional splinting or bracing pattern, or maybe you want to modify the task, because much of the recovery cannot be guaranteed, because again, as I've told you, the pattern has organized, and once the pattern has been organized over a period of 6 long years, the muscle groups itself must have been organized. So there must be structural changes already incorporated. The dominant muscles must have gone for shortening because they're not letting go, and the non-dominant muscle group must have gone for lengthening. So the length tension relationship again has been compromised. So putting the entire biomechanical aspect and the neurological component together, I'm sorry, but we are not looking to a very good recovery. I hope I've answered the question.
Yes, sir. Let us move on to the next question. The next question is from Shruti Chaudhary. There is always a query from patient side. how much time it gonna take to regain functional pattern of the patient? How will you suggest to counsel the patient regarding it?
Yes, Shruti, it's a very, very common situation in all the physical therapists' life that the patient on the very first day they come and ask because they're already frustrated visiting a lot of centers and they have seen that the recovery process has been very, very slow. Now, resorting again to the same conceptual talk, what I've been going through so far, see, the correct movement pattern or the so-called normalized movement pattern is always going to be dependent upon how the activation phase is. So you can always talk to the patient telling that, the activation component itself is being compromised. So unless and until we have a good activation component, or let us say the initiation factor of the motion in the right line, it is not answerable or it is not commentable how early the recovery process is going to be. So you can rather counsel them or you can rather respond them in terms of phases or stages of recovery, what you are expecting to get from the patient, although it is highly possible that the patient might not be able to gain the entire scenario. So the patient party at least has an understanding regarding what kind of condition we are looking at and what kind of recovery stages we are supposed to be looking at. So they will not question you on and off, sir, what next? Ma'am, what next? How many years? How many months? Because as I told you before, unlike orthopedic sciences, we are not dealing with the healing process of fracture over here. We are dealing with the healing process of movement over here, and movement is not generated by a single component. We have a neuromuscular, musculoskeletal, and the entire body working behind it. So again, just to answer the question, you might just need to resort to the pattern of activation, or let us say initiation, execution, and termination, because this question never stops. Right? I hope I answered the question.
Yes, thank you, sir. The next question is from Dr. Vishnu. Is mobilization of hand complex indicated in stroke?
By mobilization, what is the idea, sir?
Dr. Vishnu, kindly clarify your question in your live chat box, or if you are available in Zoom, kindly you can discuss with our resource person. So meantime, we would like to go to the next question from Lavi Sharan. Is there any chances to correct scapular protraction after post or 8 to 9 years post stroke?
I'm sorry, ma'am, but again, I would like to say the same thing. You need to look at the condition of the scapula or the retractors first. If you see that the retractors have not been over lengthened or the pectoralis major has not gained over dominance, let us say, if you can see me right now, like if you see my shoulder, if my shoulder is already into this position, it is already into protraction where the scapular retractors are overstretched and the pectoralis major has already been in a shortened stage, I'm sorry, you'll have to work more upon lengthening the pectoralis major, and then maybe we can talk about what is going to be happening with the retractors of the shoulder. A lot of therapists, a lot of senior therapists have advocated that use of electrical stimulation does help, provided with the electrical stimulation on, the patient is able to fire the muscle voluntarily. But then again, as I said, chronicity of the situation usually impacts the positioning of the scapula. So if you have a scapula which is malaligned, first you need to train the alignment, again, which requires taping or splinting or the figure of 8 brace, what we usually have for clavicle fractures again. And maybe then we can talk about, is scapula going to gain control in terms of retraction or not? So these are all conditional ifs and buts. I hope I've answered the question.
Yes, sir. Is Dr. Vishnu there? Okay, he's not there. We will move on to the next question from Manikandan. Sir, is the recovery of hand functions are same for an ischemic and hemorrhagic stroke patients?
Let me comment upon this in terms of anatomy again. See, anatomy is going to be hampered in both the scenarios, sir. If it is hemorrhagic or ischemic or traumatic or what we need to look into is what area and how much area has been hampered post-trauma. Trauma in terms of ischemia, trauma in terms of embolism or hemorrhage or whatever. It does not depend upon what sort of injury has taken place. It depends upon what area of brain has been involved and how exactly is the motor pattern compromised. So rather than, we as therapists always are interested in taking the history. So what kind of stroke the patient has been referred with? I have a case of hemorrhagic stroke. I have a case of ischemic stroke. Well, ultimately, we as therapists do not treat either of the scenarios. What we are treating basically is the symptoms. Please let me clarify. We do not interfere with the structural organization of the brain or cortical structures or spinal cord or the tracts. What we take care of is how well can the diversion or the synergistic pattern, which is abnormal post stroke, be taken care of, so that by the time the brain starts reorganizing itself, or let us talk in terms of how well the neural plasticity is acting properly in time, so that the patient starts regaining control, either in the direct form from the same area which has been hampered, or from the indirect form from the counter side of the hemisphere. So if the question is, sir, is there any difference between hemiplegic and ischemic hand control or treatment? No, sir. The treatment is usually the same. You just need to resort to the kind of symptoms what you're dealing with and start progressing along with it. Yes, chronicity does matter. I hope I've answered the question.
Yes, sir. And from Dr. Vishnu again, that is regarding the question, mobilization of hand complex indicated in stroke. He is saying that PIP and DIP joints mobilization or MWM
Yes,
can
yes,
be
yes.
indicated.
Sir, basically, you have to look into what is happening or what is going on with the periarticular structures of the small joints. As we know of, there is no muscle post the palm section. There's always going to be just tendons going through a lot of sheaths and cross ligaments and capsules, and there are a lot of tunnels again. So definitely, yes, see, we are treating symptoms again, as I said. If you have a client who has got a good firing of muscles, but it is just because of a tight or periarticular structure which is inhibiting the motion, why not? Why not? You have to go for mobilization. So when we treat a case of stroke, basically we are looking into a complex mechanism of neuromuscular and musculoskeletal disintegration. So whatever strategies it requires to be treating the condition, you can, of course, yes, because we are going to be treating the movement on the whole. If it requires the periarticular structure to be mobilized or loosened or lengthened, definitely yes, we should go for mobilization. Why not? It is not like mobilization is a component of orthopedic sciences or orthopedic conditions, so you should not comply or apply it in neurological condition. No, it's not like that. You can definitely mobilize. But one more thing, you have to understand, in the process of mobilization, please try not to over mobilize. It is very, very necessary to understand when to stop and till what range do you need the lengthening of the periarticular structures, because if you have got any uncontrolled action at the cost of periarticular structures, I'm sorry, my friend, you will not be able to control it later on. So be in very much good control of mobilizing and understand to what limit you need to mobilize. I hope I've answered the question.
Thank you, sir. Thank you so much. The next question is from Shruti Chaudhary. There is a lot of approach like Bobath, Brainstorm. And could you tell about good approach you are using to your own patients?
Well, Shruti, I have a lot of debate. I had a lot of controversies with my seniors, with orthopedicians, with neurophysicians, neurosurgeons, because usually the resort is Bobath approach is good. Brainstorm has to be followed. NDT is always good. Well, I don't know how people are going to take this, but till date, if you go through the systematic reviews or the research article, I'm an academician basically, so I have a lot of understanding regarding this thing. Well, NDT, my dear friends, does not have adequate evidence over either of the approaches. Still, NDT is being practiced all over the world. There are results, but there is no reason to make a physiological conceptualization how it works. So usually what I do is, I don't look into what concept I'm using. I look into what is the requirement of the client. If I think the proprioception needs to be facilitated, if I think the patient needs to be focusing on a particular task in a particular component break pattern, I mix all the patterns. It is not so, I mean, even NDT does not say that I am the best. None of the approaches say that I am the best. All these approaches say that I can help you more. That means we can prove to be a good adjunct as compared to be using alone, because even if you go through a lot of researches which are going on the neurological population, you'll find that none of these approaches or techniques have been advocated to be used on entirety, because there's an ethical issue. Why? Because most of the approaches target some specific areas of the body or specific structures of the body. Well, what about the rest? Because the patient, when they are reporting as a whole. So we need to understand that you cannot stick on to a single object or single approach when we are treating the patient. You have to conceptualize based upon what is the requirement, tailor your concept or approach, and then maybe you can go for treating the client. I hope I've answered the question.
Yes, sir. Recently, I have also got some ideas regarding it, that one of a resource person saying that human being were born to walk and run and do the activities. Concentrate on that. Don't run behind any kind of techniques, he said, any kind of approaches. So you concentrate on motor control, all those things, then it will be fine.
Yes, sir.
You can
Namaste, sir.
Hello. Hello, who is that? Vishnu Priya?
Dr. Vishnu here, sir. Yeah, sir. Yeah.
Yes, yes.
Yeah,
please.
sir. So I was just listening to all those things in YouTube. So I was a bit busy. So the thing is, what I wanted to ask, that whether it is indicated, whether mobilization indicated in case of hand complex, in basically in case of chronic stroke or whatever the stroke it is. So what will be the scenario, whether we can use any Mulligan technique like movement with mobilization, that to basically, if we will concentrate over the hand complex, that to all joint mobilization, PIP, DIP. So what need to be done? That only my queries was. So can you please explain, sir?
Yeah, please. I just answered the question in the same direction before. Let me just repeat it. See, as I've told before, if you think that the hand function is being compromised just because of periarticular disorganization, like you have got ligaments and capsule and cross structures through which the tendons run, there is always a resort to use controlled mobilization technique. I won't use the term Maitland or Mulligan over here, but rather to mobilize the structure, because the primary requirement for a mobility or a movement to happen is a good joint range. If you have got a good muscle pull, but you don't have a proper range to be executed on the joint, it makes no sense in having a good muscle control. Vice versa, if you don't have a good joint motion, good muscle control is never going to be advocated. You will always go for compensation. So definitely, yes, you can go for using mobilization. Why not?
Thank you. Thank you so much, sir. Thank you.
You're welcome. Yes.
Thank you, Vishnu Priya madam. And yes, sir, what you are talking that yes, motor control itself is enough, and concentrate on the exercise itself is enough. No need to go for any other approaches and all those things.
Yes.
You can throw some light on it, sir. How exercise physiology varies from those approaches.
I'm sorry?
How exercise physiology behind only exercises and those approaches varies.
All right. So now most of these approaches were always based upon recovery of function. So what we as therapists usually forget is the ultimate goal from both the hands. When the patient is reporting to us, they don't tell us, sir, my hand flexion is compromised, my elbow flexion or extension is compromised, my overhead shoulder activity is compromised. What they report to us with is functional limitation. Functional limitation may be with a history of stroke, maybe with a history of neuropathy or whatever. What we as therapists usually look into is how well can I recover the movement. Now, please try to understand the segregation of these terms. Recovery of movement is not always equal to recovery of function. That is where most of the therapists till date are making a big mistake of continuing with only and only couch activities throughout the session and then sending the patient back. Now, when you are seeing, like in my scenario where I work every day, I see patients coming in walking, and the first thing what the students usually resort to is taking them on couch. My question is, why exactly is a person who is walking and coming to you being taken to couch? What is the idea? The patient is walking. Why can't we train the functions in more anti-gravity postures? Why can't we train the functions in more functional manner as compared to what we are doing on couch? Because the moment you lie the patient on couch, the first thing what you are totally hampering is pull of gravity. So the basic issue regarding the physiology, what we are trying to activate in case of post-stroke patients versus the so-called concept, what we are trying to use it, while using or while focusing on the use of concept, we forget what exactly is the concept going to give us. If the concept or the application of a particular technique does not help recovery or function of a client, well, that function, that concept is of no use. Like for the recent research is what they are saying is that task-based approach or task-oriented approach has given the best outcome. Now, what exactly is task-based approach? Task-based approach is basically focusing upon the function. You see or look at the function being compromised, again, resort to the concept of initiation, execution, termination. You demark the three ranges in which you need to focus your attention upon, mark or jot down which area or which range of motion needs to be taken care of, and then start focusing upon it. You are filling in the missing gap, you have taken care of the entire mobility issue, job is done. You use Bobat, you use NDT, you use task-based approach, doesn't matter. So the only thing what I would like to stress over here is, rather than using big names and jargons while treating the patients, I am an NDT specialist, I have got certified in Bobat approach or motor relearning approach. Why don't we just focus upon the functional recovery? The basic physiology to be recovered is function. It can be recovered by any concept, because almost all the concepts have got the result of bringing back mobility. They are not trying to say that at the end of function that, see, this is Bobat. No, Bobat is not Bobat unless the function has recovered. Right? I hope I've answered the question, sir.
Yes, sir. Yes, sir. Thank you, sir. Thank you so much. We will be moving on to the next question from Devi Prasad Samal. A patient with middle cerebral artery involvement, having mild shoulder flexion, good elbow flexion and extension. What can I do for poor wrist and finger movements and for combination of movement?
I would first like to, I know it is difficult to get an answer back, but the first question that comes to my mind is, when we are talking about a good wrist and hand component, are we supposed to be so well focused upon the proximal joint integrity or not? Like if you have got good flexion or good extension, that is one resort. Of course, yes, we need these areas for a proper hand functioning. But if you are having talk about the use of fingers and thumbs and wrists, well, that is a different area itself. You need the proximal stability and the intermediate zone to be used properly for a good hand function. But you cannot look into it that, sir, I have got shoulder, I have got hand, elbow, I have got forearm. Now, why is wrist not coming? Why is hand not coming? You have to work upon it. Now, what can I don't know how the case is looking right now, but if you have got, there is something called a CIMT, constraint induced movement therapy. So a lot of time therapists face this problem, sir, I have my patient able enough to use the hand, but they are not using it. If so is the scenario, why not resort to CIMT? Now, constant induced movement therapy is, please try to understand, CIMT is not useful in all the cases post-stroke. There is a rule of 10-10-10. So you have to have an active wrist extension of 10 degree followed by active, MCP extension of 10 degrees followed by active 10 degree of extension of your fingers. If you have these things, definitely you can start making the patient go for CIMT. Now, if the question is, sir, activation is not happening, you have to follow the routine protocols of activation. You can go for electrical stimulation, you can go for manipulation of objects as far as possible. But in manipulation of objects, please remember, start from gross to fine motor. What the therapists make mistake is, we usually start making the patient do all fine activities first. For fine activities, you need the thumb, my dear. If the thumb is not acting properly, forget about fine motor activities. And that is where we make the patient understand, sir, your hand is still not ready. Well, maybe the hand is ready for gross motor activities, where the thumb is going to go in a gross opposition manner for the fingers. For fine motor activities, you need IPs, PIPs, and DIPs again. If there is no issue with the mobility of the joints, definitely, yes, you can start using electrical stimulation aided or FES aided hand functioning, if it is available, because FES is not a usually available apparatus. It is costly. I hope I answered the question.
Thank you, sir. And we will be moving on to the next question from Jenny Patel. Sir, is it possible to gain voluntary opening of hand after 4 or 5 years post-stroke if patient still has spasticity in wrist flexors?
Jenny, let me go back to the same idea again. Chronicity is always linked with learning. Learning in terms of learning faulty patterns or learning faulty activation of the muscles. If the patient does not gain voluntary control of opening of the hand, I'm very sorry, the active extension of the entire hand complex is definitely questionable. But then we have got, as I told you, if remedial approach is not possible because 4 years down the line, activation has not come. So I'm definitely sure the extensor aspect must have gone to wasting or shortening or whatever, lengthening. So you can always go for a resort to certain splints, or there are commercially available gloves in the market which will involuntarily extend the fingers and hand for you, and all the patient is supposed to do is use the flexor synergy to the advantage. So this is also a concept. When I say about or talk about substitution and compensation, why not use the so-called over-dominant flexor synergy to advantage when we know that the extensor component is not going to develop anymore over a period of time when you have been following the client? You definitely can resort to this area, because all again as the patient needs is function. If the patient is gaining function by gaining that, I mean, passive extension of the wrist and fingers by using the glove and using the active synergy pattern, they'll be more happy than learning that I'm sorry, sir, the hand is not going to go into extension. I hope I've answered the question.
Yes, sir. The next question is from Shruti Chaudhary. Sir, catheter should be there until the patient regains functional level, or what?
I'm sorry, the first one.
Catheter. Many may have urinary catheters, all those things. So the Shruti is asking whether it should be there or not till they gain functional level.
Yeah, again, this question is beyond the scope of this presentation, but let me answer because I have been handling cases like this also. Now, Shruti, I think catheterization basically, if in case of males, you might be having Foley's. In case of females, you can have both. I mean, in case of males, you can have condom and Foley's, and in case of female, you can have Foley's. So the problem usually is in understanding whether the patient needs the catheter or not. Secondly, is the patient able enough to void urine on voluntary basis or not? Control. In case if the patient does not have voluntary control, you will have no option but to make them go on catheterization. The only reason behind which is you don't want a secondary complication of urinary tract infection. Well, in case of females, definitely for sure, and in case of males, if they have got indwelling catheter, again the issue remains the same. After every week, or usually if you are using a good company catheter or a hygienic situation or condition, you need to change them at the end of 2 weeks or 2.5 weeks. But then catheter should be used or not is a question of if and but again. It does not have any direct relation in terms of our rehabilitation protocol. So I don't know in what context the question has been asked, but it is a matter of if and but, because even if you use catheter, it is going to cause trouble. Even if you don't use catheter, it is going to cause trouble.
Okay. The next question is from Austin. If the upper limb is affected by an MCA stroke, is it a bit challenging to regain the movements?
Yes, definitely yes, because among the 3 patterns as of ACA, MCA, and PCA, MCA recovery process is advocated by a very early, recovery of face and lower limb, but the upper limb is usually challenged because of the areas of the brain which are primarily controlling the upper limb section, as of what we understand by the concept of motor homunculus. If I am not missing the concept right now, so motor homunculus area has got a very profound distribution of the upper limb in case of MCA. So MCA case are definitely challenging, but as I said, it depends upon the severity of stroke, whether mild, moderate, or severe. It depends upon that golden hour post-stroke. You know, the happening of the stroke incident post which there is a stage of the point of localization of wound or injury and ischemic penumbra. That is the viable cells around the point of impact in the brain. If that golden hour is taken care of in the right time, maybe the severity of hand involvement can be reduced. And again, that will have a direct impact upon what is going to be happening with the upper limb. So, but yes, MCA cases definitely have got a challenging upper limb to be treated. Yes, I hope I've answered the question.
Yes, sir. The next question is from Raghav.
Raghav
Jadan. I want to ask about fine movements of patients after stroke, like writing, etc. In some cases, recovery started from proximal shoulder.
I'm not exactly getting the concept of the question, sir.
I think Raghav Jadan, you are there in the Zoom. Can you please unmute? Tuna madam, kindly check Raghav Jadan.
Probably he is not here. He was there. He was raising his hand once,
Okay.
but I am unable to find him in the list.
Okay. From Michelle, can we still reverse what is wrongly learned by a stroke patient in 6 months after?
It is very I won't say difficult, but it will be an injustice to answer this question because, again, as I said, we in the neurological sciences area cannot resort to time-based recovery. I mean, if you have got 5 people aligned in a row with the same age, sex, kind of brain structure, kind of injury, all the 5 of them are going to have a different kind of recovery process. So depending upon the relearn, I mean, we have got 2 terms what we usually use in case of recovery process, that is called as re-education and relearning. Now, you see, re-education means we are just trying to resort to the old patterns and we are just trying to rewrite them. But if the case is all the way down the line that there's a severe brain injury and you need to totally recode or rewire the brain system by writing a new concept or new code, that is relearning, we'll have a substantial amount of time which we require to spend behind the recovery process. So I am not in the right state or right authority to answer this question because there are different modes of recovery processes again. So you need to have a very profound look into how exactly is the patient recovering over a period of time. And then maybe you yourself might be able to be in a position to answer the question. So to discuss it in a hypothetical sense will not be justified.
Okay, so the next question is from Arjun. When compared to the larger joints, why smaller joints are mostly affected in stroke? What is the reason behind it?
I will not agree with that, Arjun, because usually we see more complications of shoulder as compared to hand. I mean, whenever we even resort to research literatures and theory, what we usually study in books and all the articles what we have, we don't see hemiplegic hand as of what is happening with the hand. We usually see hemiplegic hand as what is happening with the shoulder. So what usually happens is, as I've told you before, that recovery is a proximal to distal or central to peripheral process post-stroke. So the reorganization of the corticospinal tract, or let me precisely say the control of inhibition, which is lost exactly. See, post-stroke, what happens is the brain or the cortical system loses its inhibition control, or let me put it in a better term, is controlling control or regulation control over spinal cord, which is actually firing the spastic features. So if the distal most aspect is not taken care of in the right time, that is one scenario, or if the control does not develop in the right time, that is second scenario. Definitely, yes, the scene is going to look the same as of what we are expressing right now, as of why does the distal section or the smaller joints have more problem to get recovered as compared to the proximal joint. The second way of looking into this is that the distal joints or the distal component of the hand was not ever used because the proximal stability was never organized enough to stabilize the upper component so that the lower component can ever reach to an object for being grabbed. So this is another way of looking into it. But otherwise, I would actually like to disagree with the fact that why distal joints and why not proximal joints. I hope I've answered the question.
Thank you, sir. The next question is from Ivy Ranesses. In early rehabilitation of stroke patients, some patients gain movement first in distal part, like flexion of digits rather than arm flexion. If I understood your lecture earlier, we need to focus on the proximal part first, even though the initial movement was in fingers. Is
Absolutely,
that right?
yes. Yeah. See, as I said, you see, you cannot overlook the recovery of the distal component and just stick to the concept. No. First the proximal aspect and then the distal aspect. As I've told you before in the lecture that if the distal aspect does show a better recovery or a better control, you cannot let it go at any chance. Because ultimately, as I've told you, the entire essence of having an upper limb functional is at the cost of a good hand. Now, in the process of making the proximal stability come first and gaining the proximal stability, which definitely might take time, because as I've told you, I narrated the case, one of my clients does not have still at date, post 7 years of stroke, the activation of anterior deltoid, precisely anterior deltoid and triceps. He cannot merge these two muscles. If so is the scenario, you cannot just resort to the fact that, sir, proximal stability is not there. I will not do anything with the distal mobility. No. I already told you that you can have a hands rehab station or a workstation where you can very well stabilize the elbow so that the proximal component is not utilized at all and start messing with the distal component. You cannot let go of the fact that the distal component is active. You have to work upon it as and when available. But then at a later date, please try to understand you have to start merging the two, because otherwise also, even if the hand is functioning, but the shoulder and the elbow complex or the forearm complex is not in the action, it makes no sense. I hope I answered the question.
Yes, sir. Thank you, sir. And there is another one more question, but it is related to craniotomy. Since you are a neurophysiotherapist, I would like to take the question, and
Yes.
because maybe this physiotherapist couldn't have any other opportunity to discuss.
Sure,
So,
sure, sure.
any contraindications regarding use of muscle stimulator in craniotomy patients?
All right. Again, the question is incomplete basically, but then there is no reason why you should not use electrical stimulation in craniotomy. Please let me try to elaborate this. Electrical stimulation is done on a peripheral organ or an appendage, which is nowhere near the central nervous system. Secondly, electrical stimulation current formats or the current forms or the waveforms what we use usually don't cross the spinal cord and reach the brain except for the sensory component. I mean, I have never heard or never read in any literatures that giving electrical stimulation to a wrist musculature or a forearm musculature fired or triggered some exceptional EEG pattern in the brain. Of course, it is sensed. The brain area number 312, which is primary sensory cortex, registers that something is going on. But then there is no resort or there is no proof or backup saying that electrical stimulation is going to harm or worsen the situation in case of a craniotomy patient. No, there is no resort. You can do electrical stimulation. Definitely yes.
Yes, thank you, sir. Let me check if there are any questions left unanswered. From Mari Mutubi, well, we need to have a holistic approaches to bring them functionally near normal instead concentrating on a single technique. He's sharing his view.
Thank you. Yes.
Tuna madam, is there any questions left in Zoom?
I think no, sir.
No.
No personalized questions received. Any?
Hello.
Yes, yes. Anybody? Yes, Praveen. Yeah. Unmute yourself, please.
Sir Akhil, sir, myself.
Okay, Akhil, please. Yeah, Praveen is also raising his hand. That's why.
Sir, how can we overcome a chronic hemiplegic cancer in which the patient is not having even finger flexion, also not having finger extension, and also the main barrier is the pain, sir. Because of pain, the patient is not allowing us to even mobilize or stretch the hand. So in such situation, what will we do, sir?
Well, Akhil, I think we are looking into a case of CRPS, what we usually talk in terms of central sensitization issue or chronic regional pain syndrome, because it is a very common situation in case of hemiplegic shoulders, because if you have got recurrent subluxations or an ill-managed case or a lately managed case, I would like to say in precise sense, the patient usually has got a swollen hand component and the patient's joints are stiff, and even little amount of motion causes a lot of pain. But in that case, you need to have a team approach. You need to call in medical specialists. They need to administer medication so that the patient's tolerance level is increased. The patient's secondary features of CRPS are taken care of, and then maybe to a certain extent we can start helping. But again, if the patient's hand has not been used for a long time, and then after taking care of CRPS, again the question remains whether the patient will be able to activate the hand or not. But in case if the patient is in a state of using the hand, but just because of pain, the patient is not able to use the hand, I think you need to call in a medical facility. And from the physiotherapy point of view, you can go for contrast bath, at times Vex bath, which is discarded technique nowadays, but yet it helps. At times, even phonophoresis and electrophoresis helps. I hope I answered the question.
Yes, sir. The next
So this
question.
patient has already undergone a 2 to 3 doses of Botox injection, sir. But even though no improvements.
Why Botox exactly? See, Botox basically is given for inhibition of the spastic component of the upper limb when it is not manageable by physical therapy or it is way beyond grade 2 or 3 of modified Ashworth scale. I mean, pain and Botox do not actually comply in the same line of treatment. So I don't know exactly why Botox was given. But then Botox, if it was given on to promote, I mean, where was the Botox given, on the flexor aspect?
On the shoulder, sir, shoulder aspect.
No. See, shoulder Botox has directly, I mean, it has not got any direct context with use of hands. So in case if your question is, sir, despite of having a Botox done in the shoulder, the patient is not able to use the hand, I don't, to my knowledge, at least so far, I don't have any resource literatures telling me that Botox being injected in the shoulder is going to reduce the pain in the hands and the hand is going to be usable. So I think there is something on the other side.
Okay, thank you, sir.
Yeah.
Thank you, Akhil. The next question is from Praveen. A shoulder dislocation during stroke, how to cure? Can we give electrical stimulation to shoulder muscles like deltoid, trapezius, etc.? Is that effective?
Definitely, yes. Again, depending upon how bad and how chronic is the situation, because a lot of time patients who are unaware that physiotherapy exists and they can be helped by physical therapy, or the doctors don't refer them to physical therapy, are just made to wear slings. Yeah, they don't even know how to wear slings. So in an attempt of keeping the hand close to the shoulder, they just let the sling go loose because it is irritating, and the sweating and the itching component is so bad that they try to keep the sling as loose as possible just to have a moral feedback that at least I'm stabilizing my hand. In an attempt to do so, they lose the concept of alignment of the humeral head inside the glenoid cavity. So if you have such a situation, please try to make sure that deltoid is definitely supposed to be stimulated, especially the lateral deltoid component. But then you have to modify the splinting process. Instead of giving the usual arm sling, what we have post fractures also, you have to switch it to something called as axillary muff collar and cuff. So you have a figure of 8 kind of collar, and you have got an axillary cuff over here. So what is the difference basically in these two structures is, the first case, you have got an internally rotated and adducted shoulder, which again promotes the outdrawing of the humeral head, and it further hampers the deltoid. In case of the other sling, what I just told of, it pulls the humeral head up. So rather than stretching or lengthening the deltoid, it will rather aid the deltoid pull, and plus the electrical stimulation. So that post-electrical stimulation, when this splinting is done, or even taping is a very good example, but then taping is a bit tedious because the skin reactions might show up, or maybe every time you want to go for stimulation, you might need to remove the taping and redo it, which might not be even monetarily feasible. So probably what I'm sorry.
Rigid taping or K taping?
So that's what I'm saying. See, rigid taping is a very good answer, but then if you are trying to mix taping, rigid taping with electrical stimulation, you are going to be requiring to, you have a triple stirrup system. You have got anchoring on top and the lower section, and you've got triple stirrup system when you stabilize the humeral head inside the glenoid cavity for shoulder subluxation. In such a scenario, you are actually covering all the 3 fibers of deltoid. In that case, if you want to go for stimulation on daily basis, you have to remove the tape again and reapply it. So if the patient is fine and the skin reactions don't show up, it's a very good option. I hope I've answered the question.
Thank you, sir.
Are you clear, Praveen? Rakil?
Yes, sir. Yes, sir.
Yes,
Yes, sir. And one more thing, sir. So nowadays we are using transcranial electrical stimulation or transcranial magnetic stimulation for the treatment of this hemiplegia, sir. So can you share some of the experience with us, sir?
All right. See, transcranial electrical stimulation or the transcranial magnetic stimulation, these techniques basically were designed or founded for patients with Parkinsonism, because the dopaminergic pathways were not getting activated and the increasing dose of dopamine were not being tolerated by the client because of the side effect of sedation and delirium. So transcranial electrical stimulation actually proved to be a boon for certain Parkinsonian cases, one of which I saw in Bangalore, in Nimmans. But then hemiplegia patients being treated by transcranial stimulation is not a resorted technique yet, especially hemiplegia. I don't know why, but if you have got certain pathways or let us say neurotransmission issues, electrical stimulation of the transcranial basis helps. But in hemiplegia or post-stroke, basically what happens is there is not blockage of a pathway, there is hampering of functioning of a structure rather. And electrical stimulation inside the brain cannot make the area of the brain relive, because that is a compromised status of brain, isn't it? The neurons of the brain, which are called as oligodendrocytes, they don't have the capacity to relive. Like in case of peripheral nervous system, the neurons grow again. oligodendrocytes don't grow. And that is probably why post-stroke transcranial electrical stimulation, to my knowledge, is not a profoundly used technique so far. And secondarily, patients don't like to go for the treatment. I hope I've answered the question.
Yes, sir. Thank you, sir.
Thank you, Akhil. He was saying that many of my unclarified doubts and dilemma in mind was able to be shared and got cleared. And wonderful, Akhil. And from Rakesh, the question is how to improve supination in stroke patients.
All right. Now, Rakesh, I hope we are talking about a hand which is basically seen to be in pronated condition post-stroke. So if so is the case, primarily what happens is in case of the entire upper limb, there are certain muscle groups which are known to be involved in case of hemiplegia, one of which is pronata teres. Now, pronata teres is a very, very notorious muscle because, notorious or mischievous muscle because it's a cross-aligned muscle, right? It's a cross-aligned muscle which goes from the medial epicondyle side and crosses the forearm in the upper 1/3 section of the forearm and inserts over somewhere on the radius. Now, usually the synergy does not allow the hand to go like this. And secondly, if we as human beings, we don't use supination except for feeding or maybe some grooming activities. Usually most of the activities happen in pronation pattern. So why exactly is it so that it is so difficult to come out of pronation is because the concept of keeping the forearm supinated for the entire day itself is not understood by the brain. And that is not a physiological position for us again. That is why most of the time, whether you, me, or any patient with stroke, they'll always be seen to keep their hand in a pronated state. And that is what makes this particular scenario very, very difficult to gain. That is supination. So probably what we need to do is if the patient luckily has been available to in the very early stage post-stroke, you would like to make sure that the pronator's length is taken care of. You don't want the pronators to start executing dominating force to bring the wrist into pronation. You have to keep on tempering the patient's brain, or at least advise the caretakers to keep on, poking to the patient. Please keep your hand like this. Please keep your hand like this. The only reason being that once the pectoral artery, the pronator teres basically starts getting dominance, it is very difficult to come out of it. The basic reason is the positioning system. And that is why you have got splinting. In pediatrics, we usually use it. The splint actually extends till the mid arm. The entire hand is kept like this, right? There is no pronation allowed. So that is the only resort you can stick to. At times, we have tried taping in a spiral fashion, but it does not hold because the pull is so strong at times that the skin gets abraded. It forms blisters. So this is the scenario basically. So you can go for MFR, myofascial release technique, or deep friction massage. A lot of things have been tried. You can even try stimulation of the supinator, but usually supinator being a smaller muscle and a short line muscle does not have adequate power to gain dominance on pronator teres, and that is why most of these people resort to use of biceps. Now the fun part is biceps also is a spastic muscle in case of hemiplegia, so that further promotes synergistic pattern. So I hope I've answered the question.
Yes, sir. But I need one question, sir. What is the key muscle we need to target at the shoulder? Because whenever we tell the person to do extension at the wrist, the tricky moments occurs, like bicep flexion will occurs. Any target muscle we need to look for in a shoulder to break the synergies?
Let me go back to the same PNF pattern things what I told before. If you see that, some of the approaches also stress on this, you have to first start analyzing the motion. What we as therapists usually look on to is there are two ways of approaching a client. One is activity based, second is impairment based. Now, we have to target the activity, that is for sure, because all what we've been talking about so far is function, function, function. But then you see function basically is hampered by an impairment of a structure. Structure is usually a muscle or a joint. So definitely, yes, if you were to be targeting the extension of the wrist, and for that, if you see that there is certain kind of, hyper usage of the shoulder, you have to first see that what is happening at the wrist, which is involving the shoulder. Why is the shoulder coming in? And that is why I told you before that we usually start from passive motion to see whether if there's any joint not being allowed to move, is there any extra amount of active insufficiency or passive insufficiency or something. If so is the case, you need to take care of that. Like for example, we have got flexor dominance over here. The moment you do this, the extensors are getting weak. So probably to pull the extensors up, the patient overfires. And that is where he is compensating by using the synergy of comfort. As I told you, pronation is the synergy of comfort. So in an attempt to gain the so-called missing wrist extension, they are firing the synergy of comfort. If you see this, the first thing what you need to do is inhibit the motion. Tell the patient, please stop doing the activity now, while activating the extension when the patient is doing, especially in the missing component range. Tell them, stop firing. Do not fire. Let me complete the extension for you. Now, the question is, sir, how will this help the patient? We are inducing the sensory engram. Inducing the sensory engram at least builds the base of motion, which can be reinforced later by firing the muscle. Secondary line of approach is you can always use electrical stimulation. You see, ferritic stimulation has always been used to promote the missing component of the range. So in case if you see that 20 degree is promoted by active contraction, but the rest is being facilitated by the compensation coming in, let that be facilitated by your electrical stimulation. But you have to make sure that the flexor aspect does not have something called as passive insufficiency. The moment the extension is happening, the flexors are pulling the hand down, it will not allow the extension to happen. So basically what we do is we go for extension of the elbow, the extension of the wrist. We try to stretch the entire component out, gradually keep it on the floor or the supporting surface, and then go for extension of the wrist. So that inhibits the overstretch or the over threshold activity of your flexor components and further aids the use of extension of the wrist. I hope I've answered the question.
Yes, sir. One more, sir. Like
Yes.
usually in the flexor synergy, synergic pattern, flexion synergy pattern, any particular muscle on the shoulder we need to look for?
All right. Now there has been a lot of debate about pectoralis major. Now,
Okay.
pectoralis major is basically an antagonist to the retractors of the shoulder, right? Now, usually when the patient starts coming back from the hemiplegic state, they have got a compromised status of the shoulder girdle, let me be precise. And in shoulder girdle, let me be precise about retractors. Now, what the pectoralis major, see, usually also as human beings, we have a tendency to slouch, right? We sit with a very, very slouch back. And post stroke, again, the patient has got weakness of the extensors of the same side. Let us put MCA into consideration right now. So that further promotes pectoralis major. But stretching of the pectoralis major does not guarantee the activation of retractors of the shoulder. So rather, a controlled approach or a synchronized approach of stretching of the pectoralis major and activation of the retractors with the electrical stimulation is a better way to approach rather than stretching the pectoralis major alone. So pectoralis major and trapezius are two muscles which are seen very profoundly being used by the patients. One more mistake what the patient does is they start firing trapezius early, and the therapist mistake is they start pressing the shoulder down in an attempt to you don't use this shoulder, I mean use this muscle and perform the activity. But what the patient's brain does is it overfires the muscle against your reinforced suppression and gets more strengthened. So next time when you ask the patient to do the activity, the patient will now do this and do this. So you have further reinforced the activity. So rather than talking about which muscle to take care of, we have to talk about which muscle to inhibit. The two primary muscles what you would like to inhibit is the pectoralis major and trapezius, because these two are the culprits behind activation of the abnormal synergy at the scapula. And that indirectly reflects in the entire upper limb. I hope I've answered the question.
Very good information, sir. Thank you.
Welcome.
Thank you. And there is another one more question from Praveen. Is passive PNF effective?
All right. Now, see, passive PNF pattern, if you're talking about upper limb, we usually use it to pull out the flexion component of the synergistic pull. Now, to answer the question whether passive PNF is effective, well, passive PNF indirectly means you are just pulling the muscles which are dominating in an outstretched position or a non-dissociated, or dissociated position. Well, definitely it is effective in case of the patient who does not have any voluntary control to come out of the flexor synergy. If the patient has got control to come out of synergy, rather than using passive PNF patterns, why should we not resort to an active assisted or controlled motions or hold relax or contract relax mode of PNF? So depending upon the stage of spasticity, because in case of flaccidity, PNF does not make any sense. You are going to be overstretching the muscles before they even start getting dominance. So in case of, let us say, grade 3 or grade 4 post spasticity development in brainstorm stage, definitely yes, passive PNFs is going to be it's a good resort because it stretches out the entire pattern rather than stretching the pectoralis major alone, then biceps, then rotators, etc. I hope I've answered the question.
So one final question from
Yes, sir.
Nasif. If the patient is unconscious, that is, he is responding, be looking towards a vocal sound, what is the possible treatment we can give to the upper extremity?
I think we are talking about the patient who's recovering from a severe stroke where the patient had unconsciousness and the patient has started gaining consciousness. Well, we are undoubtedly looking towards a case where the patient is lying flat on the bed and in flaccid stage. So again, as I've told you before, in the early stages of stroke, the primary requisite is to maintain the structures which we already know are going to be challenging later on. So now usually the question comes to my mind, and I've been asking a lot of people in my UGs and PGs, but no clear question answer is coming. Why exactly flexor synergy in upper limb and why exactly extensor synergy in lower limb? What is the reason? And if so is the case, why exactly at times extensor synergy in upper limb and why exactly flexor synergy in lower limb? So usually the answer what has been given to me and what I can only resort to right now because I don't have any proof for that is the positioning system post stroke is what actually makes the synergy dominant. Now, if the question is regarding what can we do in this particular stage, you are just supposed to make sure that till the stage lasts, because we don't know again post stroke how long the stage of flaccidity or inactivity is going to last. We can just make sure that certain muscles, like for example deltoid and quadriceps, we know that these muscles are going to be very early atrophied. These are already anti-gravity stress muscles. You have to take care of them profoundly. You have to make sure that all the joints are being given compressions in the longitudinal way so that you don't allow any porosis to come in, although porosis cannot be expected to come in as fast as what we are talking right now, but then it all depends upon age. You have to make sure that the positioning system is taken care of because the patients will be required to turn from side to side at times when prone positioning is required. So positioning has to be done properly because if the scapula right in this stage is not taken care of, definitely the later stage scapula is going to be found excessively protracted. So I don't think we have much to do. At times there is a debate, should we electrically stimulate the muscle when the patient is lying in bed? Why not? My question is why not? Because even post that, when the patient is going to be in flaccid stage, you are going to rely on the resort of activating the muscle, if not actively by the patient, by some passive mode, by taping, by splinting, by doing some activity. Why not electrical stimulation? So if you can do it within control, yes, electrical stimulation can be suggested again. I hope I've answered the question.
Thank you, sir. And one final question, because it's like a suggestion. Can you suggest us some books for this topic?
See, there are a lot of books actually. Why don't we resort to research articles? Because I don't actually avoid complying to books. The reason being that books are published not like every year, right? You have got n number of researches being indexed and published free text. And nowadays we even have a site called as SCIHUB, scihub.se, which is giving you immense knowledge by giving whatever articles you want and in whatever languages you want. So rather than resorting to books, I think if you write down the keywords, hemiplegic hand, or any particular symptom of your choice, it is going to be a better informative idea because not only do they give you literature background, they also give an extra added background of what they've done. And along with that, the discussion part gives you the in-depth understanding of why exactly things are not happening. So answers are also available. So rather than having a dictated material coming from books, resorting to research articles from my end is a better option.
Thank you, sir. Thank you so much. We can conclude from here. And I take this opportunity to thank all the viewers who are still watching us. Concurrently, they are following us, around 50 persons. And we are having another 50 plus participants in our Zoom meeting because the lecture was ended an hour ago. But still, they are here to learn something from the discussion part. So I thank all our participants and I thank Dr. Nancy Gandhi for suggesting us to reach you. And I thank Dr. Ravi Shah for a wonderful session. Thank you so much, sir.
My pleasure, sir. And again, thanks to the organizing team for letting me have a talk. Even I enjoyed interacting with the people who are online. Thank you so much.
Yes, and I would like to thank Ms. Tuna. Thank you, madam. And we will be winding up the session. Thank you, everyone.